So we're going to take a moment to, as we've done many times, consider the concepts that we've described previously and apply those to the fibular head. So the fibular head does have some motion capacity. It's very minor. If you are in a situation where you're assessing the fibular head and you believe that you're feeling a lot of motion, you are either encountering a patient who just happens to be fairly lax in the structures that connect to the fibular head, or you may have detected some form of minor tear or minor problem with, again, the soft tissue structures that happen to attach to the fibular head. The primary ones being soleus, and if I remember properly, the long-headed biceps femoris, but I may be messing that up a little bit. The basic idea is that the fibular head does have soft tissue tethers that are tendinous and quite strong. The fibular head may also give you some information about the knee in general. Very simply, to check into the fibular head, so as we've talked about before, shortening soft tissues to take tension off of the soft tissues can also apply to joints if you're trying to see what's happening at those joints. You have to remember that when you take that soft tissue tension out, that you have changed some of the dynamics, versus if that soft tissue tension is in, right, or on tension, those soft tissues are on tension, applying that tension to the joint or to the bony structures that you're dealing with. So one of the simple things that some people like to talk about is essentially using the ankle to move the fibular head. I'm not necessarily a particular fan of that. It does not seem to give me as much information as I'd like, just because the ankle's far enough away and it's pulling on multiple soft tissues that I can feel tension in those soft tissues on other parts of my hand if I'm assessing at the knee. So the way that I tend to assess the fibular head is I actually put the patient's knees to 90 degrees, or relatively speaking. So this takes tension somewhat off of the hamstrings broadly, which will take some of the tension off of the top of the fibular head. And then on some level, the patient's ankle is somewhat plantar flex, so that takes some tension out of the soleus. So what I do is I come to the fibular head, right? So broad contact for multi-point discrimination, move from the known to the unknown. So I have my hand up here on the knee. I know that somewhere here I'm going to feel a clear bony lump, right? So I go there. I take essentially a pincer grip. So the challenge with this is that any other grip that I have, I'll just slide over tissues. I'll slide over bone. So here, this pincer type grip on the front and the back of the fibular head will allow for some glide, right? It's going to be a very, very, very small glide. A fair amount of what I will interpret as motion of the fibular head will actually be my fingers squishing and rolling a little bit. So that's why I have to use my eyes, because I can do this and think I'm moving the fibular head, but if I use my eyes and I focus on what's in between my fingers and try to glide it and only it without allowing my hand to roll around, I'll get some better information. But this, in and of itself, so a posterior glide and an anterior glide of the fibular head, whatever you happen to find, if you find that it seems to show a very minor motion posterior and almost no motion anterior, then you have your diagnosis. It's essentially a posterior fibular head, at least in this position, and then what you're able to do at that point is either go indirect or direct. So you go the way it likes to go or the way it doesn't like to go. All right, so you're considering relational motion as well, even in the diagnostic portion, because the tibia is fairly still and the fibula will move somewhat in relation to it. So you have your short lever option here, just an actual glide, using your eyes to make sure that you're not rolling your wrist, that what motion is happening is actually happening at the fibular head, keeping in mind that it is mild. Another option for working in and around the fibular head is just essentially a wedge type movement. So based on the angle of the camera, this may not necessarily show up well, but what I will often do is I'll come underneath the knee and I'll wedge here. So my forearm will wedge underneath, right? Because the wider part of my wedge is behind the fibular head, what I have is a block to its movement, right? So this is where I'm going to have a wedge, and the wedge is my forearm, the lever is going to be the tibia and the fibula by me holding at the ankle, and then I'll be able to create minor motions to attempt to mobilize the fibular head, because the fibular head will be stabilized, or as far as relational motion is concerned, I will stop the fibula from moving and I will move the tibia in relation to it. Right? So what happens is I come up here, again I'm hiding it a bit with my back, but it's going to look more or less like this. So I'll see if I can get out of the way, but I'll be in here, I'll keep my elbow tight, I'll create that wedge, I'll close the knee, and then I can roll the ankle. Right? So it won't show up particularly well with the camera angle, but basically your analog is I would have the leg in this position, right? I'd have the leg in this position, I'd hold at the ankle, so I'm nice and tight, and then I'll essentially roll the tibia and the fibula, right? And then I can also draw up with my wedge, with my arm underneath or posterior to the knee, to create that wedging force to abate the motion of the fibula, and then create some motion against my relatively still arm. So we have some options there with long leverage, short leverage, mixed leverage, using wedges, considering contact, considering me staying close to the patient, so concept of patient positioning. We're using all of these things to describe what these treatments or what these assessments look like. And keeping in mind that the fibular head does not move a large amount, it is a mild motion. I will tell you clinically, I have seen some people who have oddly mobile fibular heads, but they also seem to have general knee problems. So again, we take all of these concepts into consideration as we're making our treatments, and then we'll show you technical approaches and describe them. And as always with these videos, because they're videos, if there's something that you're having a challenge with, pause, rewind, watch it again.